That's why I'm like,
Wait, is that where we're at? You'll be fine.
you are clear.
I have $5.99.
They're bringing.
Got two pins.
Oh, okay, speaking of money.
Forget his name. He's always here.
Yeah.
No.
She used to do filthy classes where she could ask me on her mom. She could. That worries me because my daughter's not.
Oh, really?
Like, she had no friends before she could be friends.
Oh, good.
Sorry.
She's tall, but she's the ones that do.
Oh, yeah. My 2-year-old beats up on that girl, so.
She's a cute little thing. Wow. Hopefully she's
Well, the lady I went to is now in jail for sexual abuse, so. And she was a college coach, so. Education. She was a.
I'm just gonna write
Fair enough.
down a list. Right now. She really was
I liked it that way. I think she's so interested in mine. I love the night shift though. Everybody's so much more chill.
Yeah, I love Ashley and Tracy. The one Friday night.
Oh,
Ricky would get the Spitfire that.
Natalie was cracking me up.
Natalie, she sits over there.
Did you work yesterday?
Yeah.
Saturday night.
Saturday night, yeah.
Yeah, we were Saturday night. Oh, you guys, I get home. I try to go to sleep. My dad decides to play on his tractor in the backyard. So then I'm like, screw this. I put headsets in with my phone and listen to my Amazon, and that group chat starts going, did it? From like 6.
Oh, did you sleep at all?
Yeah, I got naps here and there.
I slept till 3. And then I wake up.
Oh, wow.
I got it.
Yeah.
Oh, in the morning. It's too early.
Yeah, my time.
I actually already started doing real stuff. Huh? Come with me. She's there.
Would you mind?
I don't even know this. So much stuff I'll go.
There. Just there. Okay. And that's all you do.
I seen them.
A few little
I
lines,
had
or
to
like
go
a little
trade,
rat bite
so
or
I
something
had
in
to
the front. And
sort
I'm
of-
like, please don't do it.
Why?
It's so cool. It's a weird. I would do it if I could. It's a weird.
Okay, we're gonna get started in just a couple minutes.
Okay.
Okay, we're gonna go ahead and get started.
Elk City's here and we hear you.
All right. I know your brains are fried. You just had a test, but it wasn't that bad.
Yeah, it was.
Okay, so we got we got 2 chapters to cover. So we're gonna go through it kind of fast and furious because we got to be done in about an hour. Okay? Everybody cool with that? All right. So chapter 17, the somatic symptom disorders. I know when Miss Walker lectured, she said that a lot of people think that mental health is dealing mainly with the brain, but somatic symptom disorders is basically the body part of it. Soma is basically your body. So that's what this whole chapter is basing their information on. Somatization is the expression of psychological stress through physical symptoms. A lot of those symptoms will be, I don't know if you've ever had somebody tell you, oh, this hurts or that hurts, but they go to the doctor, they have all these tests done and nothing's wrong. That's basically their way of expressing anxiety, depression, things like that. It comes up in a lot of different ways. Anxieties can make you feel like you have physical ailments. You know, somebody's neck always hurts or this arm always hurts, but there's nothing wrong. You've had x-rays, things like that, and nothing comes of it. You'll have to basically take their word for it because, I mean, it's subjective as far as what pain is. And if they don't have a psychological team or anything following them, it's basically what they're telling you and you're taking those symptoms. Irritability can also be one that they'll feel physical symptoms from. In somatic symptom disorders, the primary focus is on the physical manifestation of the emotional symptoms. Some of the disorder types are your somatic symptom disorder, the illness anxiety disorder, conversion disorder, factitious disorder, and psychological factors affecting medical conditions.
Like when people have anxiety attacks in their chest hurt.
Yes, Exactly.
So that you can't breathe and you go into a panic attack.
And then you just keep piling stuff on.
We can't hear what the student's comment was.
Oh, it's just that like when you have an anxiety attack and your chest hurts. Their suffering is going to be authentic. It's real to them. So don't play down their symptoms. You have high level functioning impairment without significant physical findings. So like I said, they have x-rays done or something like that and nothing's found. Just like you said, the chest pain, fatigue, dizziness, headache, swelling, back pain. It actually results in like 40% of all visits to their primary care providers. And primary care providers don't find anything, but they genuinely feel that there is something wrong. A lot of times it can be, headaches, pins and needles. I feel like crying all the time. Mood changes, dizziness and balance problems, diarrhea, constipation, nausea, all these things. With these, your DSM criteria boxes on page 316 and 317, know the difference. Some of those can be kind of similar to each other for the somatic symptom disorder and the illness anxiety disorder. Just know the difference between those. With illness anxiety disorder, it's previously known as hypochondriasis. It's a misinterpretation of physical sensations as serious illness. People that have illness anxiety disorder, they experience extreme worry or fear about the possibility of having a disease. I don't necessarily have it, but I may get that. Or it's somebody within the friend circle or somebody that knew somebody had it, so it's a possibility I could get it. That's their biggest fear, is contracting an illness, even though it may not have anything to do with them. Conversion disorder, that's also known as your functional neurological disorder. MRI studies suggest that patients with this disorder have an abnormal pattern of cerebral activation. The neurological symptoms occur without a neurological diagnosis. It sometimes can be transferred to physical symptoms as well. They may show lack of emotional concern about the symptoms, but some of the symptoms can include things like paralysis, blindness, movement disorders, gait disorders. So they're walking and there's a noticeable limp, or one leg shoots out one way when they're walking all the time. They have numbness, loss of hearing, episodes resembling epilepsy. So it can manifest in many different ways. Intervention should be supportive, but matter of fact, and not where they're dependent upon you or their support person. Let's see, some of the things that can cause the conversion disorder are like childhood physical or sexual abuse. Most patients that have conversion disorder have experienced that in some way, shape, or form. Reoccurrence is high in conversion disorder. It happens 25% more often within the first year after they've had treatment. There are also, these cases can be are usually found with a comorbidity, medical or neurological or condition. And the conversion disorder normally exaggerates the medical or the neurological condition. So it just makes it worse.
But they actually have a neurological? Like,
They
is this the one where
can.
they don't actually, because we were doing the pass points and they were saying, they came in for whatever and then had like paralysis that was
That's exactly.
related to.
Yes.
Okay, so that's what this is.
Yeah, that's exactly what it is. If you had somebody that had paralysis and they sat there for a while, they told you that I can't do
I can't feel my
anything
legs
or
anymore or whatever.
and it lasts for a little bit and then they're okay.
Oh.
What else? Like I said, the childhood trauma or sexual abuse, it's reported in 20 to 50% of patients. That also goes, well, we'll get to that in the next chapter. I think that's it with that one. Psychological factors affecting medical conditions. Stress can negatively affect any condition, medical conditions included. Some of the more common ones are like cardiovascular disease, peptic ulcer disease, cancer, tension headaches, essential hypertension, things like that. It kind of increases the symptoms that they're having. So they may have medications that are controlling hypertension, things like that. You get stressed, of course, your blood pressure goes up. So it's more one of those that you kind of have to calm yourself. I mean, that's easier said than done, of course, when you're stressed out, but some things are out of your control and you kind of have to let them go. On page 321, there's a table that shows like some of the things that you need to assess for when you're looking at your somatic symptom disorders. Those are a lot of the things that you have to look at as far as like their past history, if they do have any traumatic events, things like that. You're looking at their social life, their home life, for things that may be causing these problems or maybe causing them to think they have these problems. The psychological factors, well, the complex assessment is the psychological factors, their coping skills, spirituality and religion, secondary gains, cognitive styles, their ability to communicate feelings and emotional needs, and dependence on medications. Medications will be a big part of most of your mental health things. The self-assessment, you want to know, are they aware of their own feelings? Do they know what their feelings are towards things? Can they express those to you? And like I said, I always try not to play down their feelings or their symptoms. Just be there to listen, basically. You're a listening ear. Some of your nursing interventions, you want to do therapeutic relationships. You want to help teach effective coping skills, relaxation techniques, assertiveness training, things like that. And I know somewhere in your book, in the first chapters that you went through, you had like a meditation box that showed you some of those things. Those are things you can express to the patients and teach them.
When you say assertiveness, do you just mean like teach them kind of how to do things for themselves, not necessarily like be overly
Not necessarily be
assertive to other
aggressive.
people?
Yeah. No, we don't want to be aggressive.
Right.
But we're teaching them basically to be able to express themselves. Don't be afraid to
Instead
say
of
how you're
isolating
feeling.
themselves.
Exactly. We want them to implant themselves into the group rather than take themselves out. There's a lot of nursing diagnoses that can go along with these things. On 323, there's a box or table. No, it's not. Or is it at? Oh, on 323, the nursing diagnosis, the biggest one will be ineffective coping. Some of the other ones, anxiety, powerlessness, hopelessness, social isolation, altered family process. That'll be one that will go along with if they are patients that have attempted suicide or have family trauma, things like that. The altered family process will be a big one for that. There's also like short-term anti-anxiety meds, but those are short-term mainly because they have a large risk for dependency. Antidepressants may be directly helpful by reducing the depressive symptoms and then thereby the somatic responses, but also indirectly are affecting nerve circuits that affect not only mood, but fatigue, pain perception, giddiness, and some of the other somatic symptoms as well. I think that's it for that one. With factitious disorders, that one's also known as Munchausen. I know a lot of you have heard of Munchausen disease. Yeah, and by proxy. Yeah. This may be physical, psychiatric, hallucinations. There have been, I know you've heard of cases where people have like done GoFundMe accounts for family members with cancer or things like that. Then it comes out later on after they've collected thousands of dollars that nobody ever had cancer. It's more just for the attention. You also have, it's the Munchausen by proxy is the basically factitious disorder, but it's imposed on someone else. Usually it's a child. It could be a spouse. If they are already ill, they may continue to take them to the doctor and they always come up with another ailment. When you're in the hospital, you'll see patients that do this quite frequently. They are known as our frequent flyers. They will come through several times a month. Some of them, when they do come through, they're there for 3 to 4 weeks at a time. And every time the doctor comes in and sees them, when they start to say that they're getting better, then all of a sudden I have a new problem. I have a new illness. This is going on, or this has gotten worse, or that part got better, but now it's this. And a lot of times it'll be people that have diabetes along with other things that are going on. They will basically, once we're thinking about this one problem, say it's a hiatal hernia or something, they had a surgery. So we're looking at that right now. So my sugars are fine. But once this is better and it's time for me to go home, now my sugars are back up. We as the nurses are wondering why their sugars are up. Well, it's because families are bringing in gummy bears and Mountain Dew, ocean water slushes from Sonic, things like that. But when you go in a room, a lot of times you won't see any evidence of it because they eat it all while the family's there, and then the family takes the trash out with them. And then you'll have some that are really bold that just don't care, and you see gummy bears and you'll see a basket of candy, and you're wondering, why are you doing that when you know you have diabetes? But it's basically so they can continue to stay in the hospital. And once you get their sugars under control again, there'll be another problem. You have patients that will have surgeries and have drains or something like that, and they'll pick at those drains. They'll get infections. Then it turns into an abscess. Well, then we got to go back to surgery. So then that gives me another 3-4 days at least in the hospital.
So on your end, like when you chart stuff like that, because I'm thinking, how can you chart something like that? Like if you're suspecting them to have this, how do you chart without seeming like, oh, they're just here for attention? Or how do you chart that without seeming like we know you're just here because you want attention?
You chart what you see.
Observation.
You don't chart your opinion of it, how you feel, what you feel they're there for. You chart what you see. If you go in and the patient has been picking at that drain, or they're picking at stitches, or they're pulling off steri strips, or they have a packing in the midline dressing and they're pulling that out and then putting it back in, that's what you chart. You'll have to basically go in and change that dressing because now it's no longer sterile. They've been picking at it, pulling it out, putting it back in. So to try to reduce the risk of infection, you're going to change the packing, change the dressing, everything, and try to cover it up to where they can't get to it. You're going to report that to the doctor.
Well, so you're charting what they're doing, and then you also are gonna fix that situation and then document that, so then you're covering your own.
And you just keep re-educating you, even if they don't.
Yeah.
Education is your biggest thing. You're always educating. So when the doctor comes around and they ask you, how's this patient doing? Sometimes they'll ask you, sometimes they won't, but you keep an eye out for the doctor. And when they come around, you catch them and say, hey, This is what's going on. This is what I did. I mean, I've educated them. You may need to talk to them as well. And sometimes they will, sometimes they won't. You do what you can do as the nurse. And you're always advocating for your patients. So even though it's not trying to get something for them, it's trying to bring it to the doctor's attention because they're not the ones that see it, you are. Have a question? Okay. The big thing with factitious disorders is malingering, which is a consciously motivated act to deceive based on the desire for material gain. So that's just like I said, setting up GoFundMe accounts for things that don't exist. This is why a lot of people are hesitant to donate money to GoFundMe accounts because they don't know if they're real. Sometimes with the factitious disorder, it's biological factors, things like brain dysfunction, so impaired information processing. So they don't process information the way everybody else would. It's all about what can I get out of this situation? What can I gain from this? And that's how they think. Psychological disorders, hospitalizations perceived as refuge from chaotic home life. So those patients that are frequently there, that return after they've been gone for only 2 days, that's why. They don't want to be at home. And they may tell you, oh, my family's great. They'll be coming to visit me every day, but when it's time to go home, we got a new problem. We can't go home today. And that's the reason why, because they don't really want to be at home. We as the nurses from the hospital, we don't know what their home life is like. We don't know what they go home to. In cases like that, you can get social services or case management involved. If it's an elderly patient, we can also do APS. But you always want to report things like that to case managers. And they can get the ball rolling as we need APS or we need something, social services. We need somebody to go make a home visit and see what this environment is like. Patients with the psychological factors for factitious disorders, they may also have a masochistic side to them, and they feel the need to be punished through painful procedures. So they need to have surgery because that's their punishment. You know, S&M, that's kind of what it is. You're just using the M part of it.
That's crazy.
So their way of getting things done is to be punished. And that's by having this procedure, by going to surgery multiple times for the same thing. Those patients that when they're in the hospital can demonstrate to you everything that they're supposed to do to take care of themselves. They also have a home health nurse who will be coming by to check on them, teaching them how to take care of wounds, how to empty drains, things like that. And they will still come back to the hospital with abscesses or that wound, that surgical incision popped open. And you're probably thinking, well, how did it pop open? What were you doing?
Everything they weren't supposed to.
Exactly. Or they were just sitting there messing with us.
They didn't do anything.
Yeah.
Usually that's what you hear.
Did that.
It just came open on its own. And you just have to say, oh, okay. But you can chart that, you know, that maybe the edges were red, or did you get something into it when you were at work? Were you lifting something that you shouldn't have been lifting? Because usually you're going to have no heavy lifting for at least 6 weeks, depending on the type of surgery that you have. So for the nursing process for the factitious disorders, determine if the patient's signs and symptoms are conscious or unconscious. Are they aware of what they're doing? Are they aware of what they're saying? Do they know what it means when they're saying what they're saying? Avoid confrontation. I know within a lot of us, it's kind of hard to say, you know, that's not what really happened. But sometimes you just have to north-south, just nod. I hear what you're saying, I understand. I'm making note of what you said. You'll also do your objective view of what's going on. But you don't confront them and say, yeah, that didn't really happen. Because that's just creating a whole new problem that you don't need. And then the doctor has to deal with, or You get that patient that every time they do come back, because they are a frequent flyer, it's, oh, she can't be my nurse, or he can't be my nurse, or you're their nurse for half the day, and then all of a sudden they don't like you and you're fired. So now we got to reassign patients because they don't want you back in the room. And you'll have that with patients sometimes. You can't take it personally. You just, personalities don't mix. They don't mesh well. You just do your job and you keep moving. If you have a patient that says, oh, she can't come back in my room, you go let your charge nurse know they don't want me back in the room. Who would you like me to switch patients with? Would you like me to take the next admit? Whatever the case may be. And the charge nurse will go in there and PR. We want to go talk, see what's going on, and then we'll switch nurses. In some cases, the charge nurse maybe have to be the one that takes care of that patient because they don't want anybody else. And they feel like only the person that's in charge can take care of them properly. And you'll have patients like that. You just basically have to let them know that you are competent in doing your job and you will give them the best care possible. Safety is also a big priority. That's going to be your number one priority, is making sure that they're safe. They're not there hurting themselves. They don't have access to anything that's going to cause them to hurt themselves. This is where you come in and knowing your patients. You need to be observing. Every time you walk in the room, you need to be looking at your patients. Sometimes you can tell slight changes in their mannerisms, things like that, but that's only if you're actually observing when you're talking to your patients. When you walk in the room, you immediately assess. That's your first thing. Even though you're not actually going in there to do a head-to-toe assessment, you're already assessing. You're assessing the entire area, the room itself. Is it messy? Are there things around that shouldn't be around? Is there like a pocket knife laying on the table? You know, you need to know things like that. Any questions about the somatic symptom disorders, illness, anxiety disorders? Any questions from Elk City or Altus? All right, we got through that one pretty quick, so let's move on to the eating disorders. So your common eating disorders, anorexia, bulimia, and binge eating disorder. You'll see not so much see these in the hospital. They normally go to mental health facilities because it is a mental thing. With anorexia, a lot of patients don't recognize the severity of the thinness. They always perceive themselves to be overweight. It doesn't matter if you see skin and bones, they see fat. It may be a person that was previously fat and they became anorexic. That's how they lost their weight. So that's all they see is that previously fat person. It doesn't matter what you say to them, they are always fat. That's why they need psychological counseling. They need the groups. They need things like that to help them. Don't assume that just because somebody is thin that they're anorexic. Some people are just fast metabolisms. They can't help it. So when you see a patient and they're underweight, don't just think, oh, they must be anorexic, because that's not always the case. They have an intense fear of gaining weight. So no matter what they eat, even if it's diet this or diet that, they think this is going to put 10 pounds on me. That's why they're always avoiding eating. And they'll sit at the table and they'll be perfectly fine with the family. They'll appear to be eating. They're usually the last ones at the table. Or they only got maybe a corner of a regular sized plate and they're pocketing. So they'll have chipmunk cheeks sometimes. Then they'll go to the bathroom and they're spitting it out. Happens. They restrict calories. They usually have a significantly low BMI, and it's way past underweight. They will always have a distorted body image, no matter what they look like. Even if they're very fit, they're usually always exercising. They do hours and hours of exercising and haven't been eating anything. So that's usually why most of them will pass out. And that's how things usually get started. It's because their body just can't take it anymore. They're going to shut down. Yeah.
So can you tell kind of by like the lab values if
Sometimes you always run labs regardless. And the question was, can you tell by lab values whether or not they have an eating disorder or anorexia? But sometimes lab values will look like that. In your urine, you'll have sometimes ketones, and that basically means that you're hungry.
can you expect their, this may be number, can you expect their like blood sugar?
Not always,
Okay.
not always, because they eat some, but it's more like, you know, when they say eating like birds, that's what they do. They'll pick up small things here, and to them, this little handful of walnuts will last me all day. Even though we all know that's not going to suffice. Some of the subtypes for the anorexia are restricting, you have binge eating and then purging. So I'm not going to eat a whole lot right now this sitting, but then I may be one of those that are anorexic and bulimic. And you can have both ends of the spectrum in one person. It just depends on that person. For bulimia, that patient is usually going to be near their normal weight. They have recurrent episodes of uncontrollable binging. They have inappropriate compensatory behaviors, vomiting, laxative diuretics, intense exercise, and their self-image is largely influenced by body image. So if they feel like, you know, even though they're fit, they may be bigger than what they really want to be, or they could be really thin, and they still are one of those people that I'm going to take laxatives, or I need to take diuretics to keep me constantly going so I can be at that perfect weight. It kind of runs hand in hand with the anorexia. With binge eating patients, they are often overweight. They have recurrent episodes of uncontrollable binging without the compensatory behaviors. Binge episodes induce guilt, depression, embarrassment, and disgust. So they'll have all these feelings about themselves after. And then they'll probably tell themselves, I won't ever do that again. It'll never happen again. But it probably will. In all actuality, it will, unless they get some type of help.
I got a question.
Mhm.
Lactic binging, that's kind of usually a comorbidity.
It can go along with either one, because as anorexic, you can binge as well. With the eating disorder factors, the biological factors, genetics, they play a strong role. If you had somebody in your family close to you that have had eating disorders, it's not uncommon to see somebody else have the same eating disorder within that family. Neurobiological, altered brain serotonin function. It contributes to the dysregulation of appetite, mood, and impulse control. A lot of eating disorders are thought to be more impulse control than anything else. They can't control that impulse to go vomit or to binge at this time. It just depends. You have environmental factors, psychological factors that'll go along with it. Some of those psychological factors are failure to separate from patterns and rebellion against the maternal bond. So if their mom was like a binge eater or bulimic or something like that, that's kind of what they grew up knowing is normal. So that's what they see. They can't separate themselves from that. A lot of times it's an overwhelming feeling of ineffectiveness, powerlessness, a learned behavior that in some way, shape, or form has a positive reinforcement. So if I can binge and then I vomit afterwards, I feel like I did eat, but I don't have to carry that weight from eating. So for them, that's the positive in it. I mean, yes.
Is there factors like people who go long periods of time without eating, and then when they do eat, then it makes them sick and they're throwing up?
Sometimes, if they eat large amounts, because a lot of times that isn't always the case, because sometimes if you go long times without eating, like some of these people that go on those shows and they're starving, but they're eating bugs or worms or something, plants, I mean, whatever they can find, that's what they eat. In that time, your stomach begins to shrink. So then when they do get back to the normal lifestyle, they'll basically binge and they're stressing it back out, but their stomach's not ready to do that right now, and it's also not ready to process those foods. So now you're gonna go vomit. So it just depends on what the situation is, what the case was before.
At what point do you, I mean, can the doctor intervene and be like, look, like you're so skinny, you're so malnourished, like you have to have a feeding tube, or, I mean, can they just refuse that and say they just want to shrivel up? And
You always have the right to refuse. They can't make you do
so
anything.
even if they have like a mental disorder,
It would have to be court ordered.
You just had a test.
I know, but it just seems so bizarre to me that you can just let somebody wither away like that. Like, it's just so sad.
But I mean, you advocate as much as you can, but you can't force them to do anything. If they're mentally with it,
Yeah.
you can't force them to do anything. We had a patient just yesterday that left. Her daughter, all family members, everybody was trying to get her to stay just to have an EGD. You just need to have this scope. She refused to do it and she left. The doctor came and talked to her and told her this would benefit you. And she did not. And she was like, you can give me discharge orders or I can just leave. So the doctor went ahead and gave her the discharge order. She gave her all the advice that she could give her. She educated the daughter, everything that she could do. And she couldn't force her to stay. And sometimes it'll frustrate you, but you cannot force them to stay. You have a question?
Yeah, I have a family member who is probably like 5'6" and 100 pounds. A lot of times she forgets to eat because of emotional stress. And she, no matter what she does, like she can't gain weight. And so like, is it necessarily, if stress is playing a factor in this, because she'll go periods of time without eating if she doesn't think about it because she's so stressed out about her, situation that she's dealing with, is that something that would be considered like needing mental help as well, or just kind of?
Not necessarily. She may just need coping skills. She may need to know how to deal with her stress. Usually somebody like that just has problems gaining weight, their metabolism is working faster than they can get food in. Those are people that are usually going to be on high protein, high fat diets. So if she's taking in large amounts of protein, things like that, you can sometimes skip a meal and not do any harm.
She's mostly a carbs person. She doesn't really eat a lot of protein.
I'll say she could just do protein shakes. She doesn't have to actually sit down and meat and things like that. She can do protein shakes and it would help boost her weight. Yes?
Like when people with eating disorders and like refusing to eat, and then how could they get it for order for like an eating tube? Is that they're not like they're not hurting anyone else?
If they're already
Ms. Johnson, can you repeat what she said? We couldn't hear that student.
She said if there's somebody that's refusing to eat, refusing to do the feeding tube, how can you get a court order to have them get that feeding tube or something like that? A lot of times, if they have mental background or they have a long history of being anorexic or bulimic, they have some psychologists or psychiatrists or something like that that can make recommendations. If they have a medical power of attorney, something like that, sometimes it can be overridden. When you go to court and you lay out all the information, all the facts, then that judge may see, you do need this. And they can court mandate. It won't always come out that way.
It's not part of like harming themselves, you know?
It can be seen that way, but that's why you're going to court. Because you're with it enough to say that you don't want to do this, but you won't do anything to help yourself. So
That makes sense.
you kind of have to weigh out both sides, which is why you have the court dates and things like that.
I have a question.
Mhm.
So, okay, say there is a court order for a feeding tube and they still don't want it. How do you put it in? Like, you restrain
Have you
them
ever
to
seen
put it-
Suicide Squad?
No, I have not.
Where they like put you in this little chair and strap you down? No?
We're not gonna strap you down. We're not gonna restrain you.
Did you read your chapters?
If it is court ordered, most likely they have an IV already because they're in the hospital and we had to go to court to get this court order to put this feeding tube in. You can give them medication. Just like when anybody goes to surgery, they're getting Versed. They're getting Versed so you don't remember anything. So once they get that Versed and they give them that pain medication or a sedative to knock them out, they put the feeding tube in. The thing that you're going to have to watch afterwards is that they're going to be trying to pull it out. They're going to want it out. You're going to have mittens. Some people are going to be smart enough to know that I can take my teeth and pull that Velcro off and put this mitten in between my legs and pull, and it's off. Even your old people with dementia and Alzheimer's, they are smart enough to know that. So, I mean, you have mittens. Sometimes you'll have to do restraints. Other times you just have to wrap it in a fashion to where they can't get to it. Because sometimes you can put abdominal binders on them. It doesn't have to be tight, but they can't get to it. A lot of times you keep their covers pulled up to the chest, tucked under the back. Your arms are out, but you can't get to everything that you need to pull, or you want to pull. So you get creative without actually restraining. Going back to question with the labs, with a lot of anorexic or binge purge type disorders, you're looking at electrolyte imbalances. Is there potassium off? Is there calcium off? It's anything to do with electrolytes, is it off? That's what they're looking at. They want to know how far off. Because we know if your potassium is too low, you're going to have cardiac issues. I mean, everything affects something else. So that's what we're trying to avoid. With the restriction type anorexic, they'll be severely underweight, and they also may have lanugo, that really fine hair that most babies come out with. They may develop that on their face or on their back. And it's basically because they're underdeveloped, basically. They're not where they should be. Their blood pressures will usually be low, pulses will be low. Sometimes they'll have a bounding pulse. You can find some people that are tachycardic sometimes, just because their body's working so hard. You'll also have patients they'll have mottled skin, like something I don't know if you heard, or you may have heard sometimes, like when a patient's getting ready to die, the nurse will say, "Oh, they're mottling," where they get those little blotches on their skin, and you can start to see that the blood is coming away, it's shunting itself. Anorexics will have that as well. When you're trying to talk to, or you're doing an assessment on an anorexic, try not to be an authoritarian or coercive to try to get them to see your side. Just basically talk to them. You just want to talk. You don't want to try to convince somebody to do something, because that's not what they really want to do. You basically just want to lay it out there for them, answer any questions they have, make them feel comfortable with talking to you. Because if they shut down, then that's it. We're done. We got to start over at square one. And with an anorexic, the primary goal is weight gain. Any way we can get them to gain weight without them being reclusive anymore, or, kind of stepping back from everything and going back to, oh, I'm fat. So just like if you do insurance or you do a smoothie and put fruit and everything in it and it's healthy, so they're more apt to lean towards that, but you can add a little protein to it and they're getting a little bit of everything that they need. You'll have some of those protein packets that people will get if they do have feeding tubes. They put it in their, like if they do insure, they put protein packets in it to boost, to give them a little more. So you can have protein packets that you can add to fruit smoothies, things like that. And a lot of times with an anorexic, you can teach them how to do things healthy and they won't see it as you're trying to make me gain weight. So if I teach you how to make a fruit smoothie and we're not putting a lot of sugar in it, or we're not putting a lot of this or that in it, and we just have to shake this little packet of protein in it, that can be totally fine. Because you're not forcing them to do something. So it's all about how you come across to that patient. Some of your nursing diagnoses will be like imbalanced nutrition, less than body requirements, decreased cardiac output, risk for injury, risk for imbalanced fluid volume, disturbed body image. With the disturbed body image, that can be considered improved or resolved when the patient is consistently satisfied with his or her own appearance and body function. So if I sometimes say I'm okay with the weight I am, I wouldn't see it as resolved, but we're progressing. So we always want to go back to our nursing diagnosis or your care plan, per se, when you're in the hospital, because it gives you interventions and things like that to do with your patients. You always want to refer back to that to make sure that you are meeting those requirements daily. And so if you are evaluating your care plan and there's something on there that says patient will verbalize that they're doing fine, that's kind of not measurable. You want to be a little more specific. You want to have a time frame. It always has to be something that's measurable, because I could tell you I'm fine, but I'm thinking about, oh, I'm not going to eat dinner tonight, or I'm not going to eat for the next week. But I'll tell them I'm doing okay. That way I'll get to go home. It's just all on how you approach the patient and how they look at things. Whoa.
The aliens are.
Okay. I guess they had to reboot. So if you had a case study, well, a short case study, a 15-year-old is admitted to your unit with anorexia. You've completed your physical assessment. What are some of the important psychosocial areas to assess? What are some of the things that you're going to be looking for?
In a patient with what again?
Anorexia.
If they have,
What was that?
Support system.
Yeah, definitely. You're going to be looking at their support system. With the patient themselves, are you going to be thinking about their thoughts on the situation, how they perceive things are going?
or if they even really want to be there or not,
Yeah. I mean, are they wanting to even get help or receive help?
or their family pushing them to be there.
Yeah, are they forced?
You want to ask them about their eating habits. Tell them to kind of write out your diet. What do you do daily? What do you eat daily? Are you doing breakfast, lunch, and dinner? Do you just do lunch and dinner? Do you only do dinner? And are you supplementing in between? There's several questions that you can ask.
Like what they're thinking about or how they're feeling when they're eating.
That's a big one.
Yeah, what
That's
thoughts are
always
going
good.
through your head?
How does eating this diet or eating this plate of food make you feel? when you're drinking that shake, how do you feel? Do you feel like you're overeating, or do you feel like it's just enough? Because then you can tailor their diet to what they feel is appropriate, and they're still getting everything they need.
Yeah, and just like in your assessment, could you, like, if, say you had an afternoon, you're assessing them, you could be like, so can you tell me what you had for breakfast?
Yeah.
You know?
That's all part of their eating habits. You want to know what they ate. And if they tell you, oh, I didn't eat, well, did you have a shake? Orange juice? I mean,
Yeah, because then that could be a teaching opportunity as well, once you check in with that.
exactly. You're thinking about is there any value attached to the specific weight or shape that they're trying to get to? Why is it that you want to be this size, or why is it that you want to be this shape? That's what you're looking for. As far as like their interventions, their psychosocial interventions, you want to make sure they're feeling safe from judgment. They feel like nobody's judging them. Focus on the eating behavior and feelings of anxiety and low self-esteem. Sometimes you can do like holistic approach and do integrative medicine, to where they're going for massage. They can do acupuncture, yoga. They can go to health classes or health teaching classes. You can educate them and kind of pull them into being the educator for other people. And also, you always be aware that you're going to have a multidisciplinary team. You're going to have several people that are working on this one patient. You're going to have so many different people that they have to talk to, that they have to interact with. So timing is going to be a big thing. A lot of times you'll find that you need to do like cluster care, and then sometimes cluster care is too much. You have to do individual things and give them a little time in between, and then come back and do something else.
I would be curious to know, like, if a parent had anorexia, like how they were feeding their children, or like, do they just cook their children a bunch of food and let them eat whatever they want, or
Not usually.
do they just kind of treat themselves, like treat their children how they would feed themselves? You know what I mean?
It depends. It's always going to depend on the person. Sometimes you'll have those that they feed their kids, but they don't feed them as much as they should, or they're not getting the right things. A lot of times the kids actually won't even know that there's a problem. They won't know that their mother's bulimic or that their mother's anorexic, because they hide it very well. It'll be somebody else within the household or somebody on the outside looking in that sees that, there might be a problem here. So it just depends.
So most of
on-
the time they don't project that onto their families. They
It's
just
an altered self-image, so they see their self as that, but their kids can be, they're like, oh, my kids are just fine.
Yeah. Yeah, so it just depends on the person. Some of the advanced practice interventions that they do are like psychotherapy or cognitive behavioral therapy. It helps the patients understand the thoughts and feelings and that influence the type of behaviors that they have. They're basically, sometimes it'll be group type things, sometimes it'll be one-on-one. It just depends on what that patient needs. It can be one-on-one, group, or family therapy. It can be a combination of all three. Sometimes it'll be that way for younger patients, kids that are in elementary school that are anorexic. That is a problem in every way, shape, or form. A lot of patients will be okay. They'll go through their therapies. They'll be discharged out of the program. They'll be all right. But a lot of times they relapse within the first year. Anywhere from 40 to 50% will relapse and go back to those same behaviors and need to go through treatment again. It's not a one-time thing. It'll always be an ongoing thing that they'll probably have to deal with for the rest of their lives. Long-term treatment may be required. It might include hospital stays, outpatient psychotherapy, and also medications to kind of boost their appetites as far as like the anorexic patients. When you're assessing your bulimic patients, you're going to be doing both the general and the self-assessment. So you do your assessment, looking at them, the entire family situation, their home life, things like that. You're going to be looking at that, but you're also going to assess the patient and have them do a self-assessment. A lot of times you'll have forms, or you can just basically do a sit down and let's talk about what's going on. Tell me how you feel. Tell me why you feel you're at this point. You want a lot of open-ended questions to get them to kind of open up to you. Some of the medical, both situations, anorexia and bulimia, you can have medical complications. For bulimia, a lot of times you'll have problems like aspiration pneumonia, arrhythmias. Of course, you're going to have your electrolyte imbalances. Menstrual irregularities is a big one that you'll have with anorexic and bulimic.
Is that because of the drastic change in the hormonal balance?
Yeah. Yep.
When they what?
A drastic change in the hormonal balances.
It's a crash diet, it changes your hormonal balance.
Like for girls that do gymnastics, that's a big thing for them. They don't get their periods early because they're so athletic. They're constantly going. It delays their period starting.
Just stress can cause that to be crazy too.
True.
So,
But that's also one of the big things that go along with it. One of the big signs that you'll see for somebody who's bulimic or binging and purging is Russell sign. And that's the calluses that you'll see on their knuckles. Because when they jam their fingers down their throat, they're scraping across those knuckles every time.
I mess with their teeth too.
Yep. The acid erosion for your teeth, things like that. They'll have sores inside their mouths because of the acid, the stomach acid that's coming back up.
yeah, and then their esophagus, they could potentially have serious
Erosion.
problems.
Antidepressants like Wellbutrin is one of the things that they'll give you to treat the depression. It's contraindicated for patients who purge due to the risk of seizure. That's why you always got to know what your side effects are, what your risks are, complications with medications, things like that. Your primary goal is going to be to interrupt the binge purge cycle and prevent the disordered eating. So you kind of want to keep an eye on them at all times. You want to be the one that after they eat, because you've given them the amount that they're supposed to have or the portion that they need to have them sit there and talk with you. If they immediately want to get up and go to the bathroom, we want to avoid that. So let's go do something else. Let's go watch a movie. Let's go play this game. We want to divert.
How long after eating can they, I guess, throw up?
I don't think there's any specific amount of time.
Well, because like, if they decide, like, say they can keep them at the table, keep them entertained or whatever, can they go an hour later to the bathroom and throw up, or will they, or?
They can, but you absorb within that time frame. You're trying to get them to absorb those electrolytes, those nutrients, proteins, things like that they need. They may not get everything that they've eaten, but they'll get some of it. And that's why you kind of want to, most people like that will not have access to a bathroom in their room. That'll be something that they have to let you know, hey, I need to go to the restroom, and they have to be escorted to wherever the restroom is.
There's a movie on Netflix, To the Road, and it's about eating disorders, and like it's really hard to watch part of it because it actually goes into like it's told from a girl's perspective that has anorexia and how it affects her life both at home and so.
We can't hear that student either.
Okay,
and everything else, and it actually shows her going through the different counseling and all the different therapies, and then even in the group setting with the group home and how they have to act in that home and a lot of the different.
he said it was called To the Bone.
Yeah.
She said there's a movie on Netflix called To the Bone, and it basically goes through the life of a girl who has anorexia and the things that she does as far as treatment and how they get treatment.
Documentary.
It's kind of a documentary, but it's told more like a story.
Almost done. Okay, so with the binge eating nursing process, you're looking at the quantity of food consumed, how often the episodes occur, and you want to be aware of their own negative reactions or see if they are aware of their own reactions. Again, a lot of times your nursing diagnosis is always going to be the imbalanced nutrition, less than body requirements. For binge eating, it'll be more than body requirements, distorted or disturbed body image, and ineffective coping, chronic low self-esteem. You also, the big part of trying to avoid it or try to help it is to do a lot of planning. We want to plan diet and exercise, not just this is what you do, go do it. We want to have a step-by-step thing for them. We want something where they can look and say, okay, well, this is where I'm at. This is where I need to be. How am I going to get there? And that's what we, as the nursing team or as part of the multidisciplinary team, want to help them with. Yeah, some of the feeding disorders that we have are like pica or pica. I know a lot of times you hear that, labor and delivery, pregnant women, they have pica. And they're missing some type of nutrient. And a lot of times they want to eat dirt, play dirt, they'll eat glue. And eat whatever that craving is.
What the heck? What you just said?
But I mean, you have like your anemic patients, they crave ice. And you'll always see them crunching on ice. But it's eating non-food items after toddlerhood. So if you see somebody walking around with glue and they got a little stick and they're dipping in their glue bottle and they're eating, they're missing something. That's a form of pica. Like I said, a lot of times you'll hear pregnant women, oh, I had an urge to eat dirt. And they eat dirt. Some of them will eat things like cornstarch, even though it is a food item. There's something within that cornstarch that they need or they're desiring. So we always want to look at their labs, things like that, to see what is off, if anything.
Could it just be like if they're like a binge eater and like someone takes their food away and they're done eating or something and they just find stuff to eat?
Not necessarily. It is always going to be a form of pica because it's a non-food item and you're not 2 or 3.
Yeah, random people don't just eat dirt and Kleenexes.
Rumination disorder, it's regurgitation with rechewing, reswallowing, or spitting without GI or medical reason. It is gross, but it happens. Avoidant restrictive food intake disorder. You're avoiding or restricting foods starting in childhood. These patients will have significantly low BMIs. They're dependent on enteral or tube feedings because they have nutritional deficiencies. So these are your patients that are usually going to have a peg tube, or we had to put a NG tube down just to make sure that they're getting things. Okay, so, question for you. If I have an adolescent patient, they fainted during gym class, they're grossly underweight, always wearing baggy clothes, skin is dry, what would you do to further assess for anorexia? As the school nurse, what would you ask?
Yeah, what they had for breakfast.
What they ate today? What's your diet? What else?
Vital signs, just because didn't you say it had the low blood pressure, low heart rate, or they could be really tacky?
Mm-hmm.
Modeling.
Mm-hmm.
Lanugo.
You're gonna ask them when their last period was. Possibly, but we're not gonna be determining that at school. So, okay.
Anyway.
So if Mr. Anderson is found to be eating laundry powder detergent on more than one occasion, what is this? There you go.
Is there any way to stop somebody that has FICA?
You gotta find out what that deficiency is and fix that. We gotta go to the root of the problem. Any questions?
Nope.
Elk City Altus, any questions?
Elk City doesn't have any.
Okay. On my, oh, we got one
Do
here.
they ever check your hormone levels? Do they ever check your hormone levels to see if there's an association with your thought process?
That's gonna be all part of your workup. When you do labs, they're checking everything. Because a lot of times the serotonin is what's off, so that's what they're checking. All right, so I'm done on my end.
Today's Lauren.
Yeah. I got my from the. Oh,
Well, I'll know if you show up in shorts. They have to, oh, hey, Spring, they probably did tell them that, but that, you guys will have to make it up another day. Wednesday, so it'll actually make up. It's part of my
Did they leave?
Spring, holler at me and let me know.